Dr. Rubin, I have a question in regards to something we talked about earlier, that how the low intensity vibration shows that your MSC cells or your mesenchymal stem cells, when stimulated, respond like a light switch. And once on, more stimulation doesn't make things or the light any brighter. You know, it's on. Now, I want to clarify for low intensity vibration that your studies also showed that young people only needed 2 minutes, but older people needed a longer period of time. So if I'm going to prescribe based on age group, the amount of time that is needed for someone to turn on their light switch, am I correct in assuming that if someone is under the age of 20, 2 minutes is the minimal time per day? More is always better, but 2 minutes is the minimal time. And then would you recommend increasing the minimal daily time by a minute or two per decade? So here's my scenario is if you're 30, you go for 3 minutes. If you're 40, you go for 4 minutes, minimal time. 50, 6 minutes, 60, 8 minutes. And if you're 70, 10 minutes. But you're the one studying these cells, you know, so if somebody purchases a low intensity vibration platform with the goal of helping their bone muscle status, what is the minimum time frame they should be on that platform based on it?
It's a great question, and I just wish that I had the studies to support your hypothesis, which I'm completely for. But you have to remember that me as a scientist, I'm more comfortable dealing with the data that I have in hand rather than trying to extrapolate to different conditions.
Okay.
I would look at it the other way around, that what we are trying to do using our low intensity vibration is to saturate the response of as many cells as possible as quickly as possible. And if you are 7 years old or 30 years old, or you're a child with a disabling condition, that all of these cells are responsive, and we want to make sure that we turn them all on. So whether it's 2 minutes or 10 minutes, I would argue that it's safest to approach this intervention by subjecting or dealing with a daily dose of at least 10 minutes. I'm a little uncomfortable trying to sort of cut corners. And that's mainly because we've worked so hard with our clinical trials where we try to control what we're inputting into the system that we rarely try to cut it back. The problem becomes one of compliance. So you could say 10 minutes per day, that's great, but I just don't have time in the day. Let's try 2 minutes per day. If it keeps your compliance up, that's great. But if I'm exercising, or if I'm standing on a vibrating device, or if I'm doing both together, the most important component of this is to do it every day. You can't say, well, I'm going to do 30 minutes of exercise today, which is going to get me through the rest of the week, and I'll wait till next Monday to go again. You want to exercise every day because your cells will basically regress back to this sort of couch potato or sedentary state unless you stimulate them every day. So by exercising every day or by buzzing every day, it's a way to wake your cells up and get them to do the right thing, to misquote a Spike Lee movie.
So you mentioned the importance of exercising every day or standing on the platform every day so that we keep the stimulus alive, you know, or we create a stimulus that keeps the cells willing to do what they do best. If someone doesn't have a platform and they're using exercise as a means of stimulating the mesenchymal stem cells, then what I need to know, and I know my clients are going to go, what is the intensity of the exercise that turns on that light switch? is walking to the fridge and sitting back down enough of a stimulus, or do they have to go for a brisk walk? My understanding is that walk has to be at least 3.1 miles an hour in order to be loading enough. And therefore, for how long, and again, my recommendation has been that if they have, the time to walk for 60 minutes a day, that I would much prefer that they walk in 3 20-minute intervals than one 60-minute interval. So, the more frequent, the better. But it's really that I want to make sure that each time they do something, that they turn on that light switch. So could you speak to the turning on of the light switch relative to exercise?
Sure, I can give it a try. It's a great question. And let's put it in sort of a hierarchy. It's better to sit than lie down. It's better to stand than to sit. It's better to walk than to stand. And it's probably better, if it's safe, to run than it is to walk. But I would argue that running for 5 hours per day isn't going to add some great gain to your musculoskeletal system than just running or walking briskly for 30 minutes per day. And there are a number of studies out, and there are more coming out every day, that show that it's the important element is that you're active. Being active is essential. So if you're cooped up in your home because of COVID, or you're just not interested, it's too cold out or it's snowing, rather than walk to the refrigerator, run to it, right? So just, I agree with you completely that if you have enough time during the day, and I hope you do, to exercise for an hour per day, what our cell studies and our preclinical animal studies tell us is that breaking that up into a number of sessions per day not only recruits more cells to be responsive, but each individual cell is actually more attuned to be responsive. So you have more soldiers in the army, and they're better armed to build up your bone and muscle. So you think of it in the context even of our fellow marathon runners are a good example. They're out running 8-9 miles per day, 7 days per week. They don't have gargantuan skeletons, right? They have actually pretty slender skeletons, and a number of our fellow athletes, female, might be amenorrheic because of over exercising, and actually have very poor bone. So there you have a situation where you're over-exercising, putting your skeleton at risk of injury, and there's no added benefit to your skeleton for doing something like running 2 or 3 hours per day, right? So turning on the light switch, if you find that right signal, turning it on, it might mean walking for 30 minutes per day, double thumbs up. It might mean running for 5 minutes per day, double thumbs up. 2 different ways to skin the cat, as it were. Standing for 8 hours a day might be just as good as walking for 30 minutes per day. Walking for 30 minutes per day might turn on the light switch just as well as running for 5 minutes per day. But if you are cooped up in your home, you're working from home because of the pandemic, etc., there's a lot of evidence out there that says, for 5 minutes every hour, maybe your smartwatch is telling you, stand up for 5 minutes it's actually a great thing. It's good for blood flow. It's good for your muscles, right, which are holding you up to sit there and vibrate away and bombard your cells with signals. Having a stand-up desk, we tend to think of, well, it's a stand-up desk. we're not sitting, right? That's got to be good. You're standing up, all your muscles are being very active. It's helping perfuse your muscle with food. It's helping bombard your bone cells with mechanical signals. It's all good. So think of the light switch as more is not necessarily better. It's a number of brief events is the best way to get that light switch on than one constant long-acting signal. Because if you miss it and it's not the right signal, you don't turn on the switch, more of it isn't going to do you any better. But just like the marathon runner who's turned on the skeleton light switch, more obviously is not producing more bone.
My next question is in regards to the work I do on a daily basis of prescribing exercise programs for individuals. Within Exercise for Better Bones, I have a diverse program so that we target as many different muscles throughout the body because we know that exercise is site specific. But I also recognize that sometimes we have to tailor a program to allow somebody to also become better at what they love to do, be it a sport or an activity. So if you don't mind commenting on that, please.
Muscle, certainly by doing different muscle groups, you have to wonder about if you're just working on your biceps, right? Your triceps probably aren't challenged. So you have to find an exercise that's then going to challenge your triceps, right? And then you need to do with your deltoids, and then you need to do your quads, etc. So I believe that a diverse exercise regimen that ultimately challenges all muscle groups is the way to universally or generically build up your muscle, and the downstream benefit of which is to benefit your bone. So again, I go back to our marathoners, who are sort of our great example in this, in that they are running for 2 hours per day in training, but you wouldn't exactly think of them as somebody in the gym who's lifting 400 pounds in bench presses, right? Because they're never actually training their upper body as much as you might think. Rock climbers, right? The way that they actually climb up rocks. They need very, very specific muscles to be able to pull them up, but they don't need necessarily to lift up 600 pounds, right? They just need to lift up 120 pounds. So again, it's muscle is going to adapt to the challenges you give it, right? A marathoner is not going to be climbing a half dome at Yosemite, just like the climber at Yosemite is not going to beat Usain Bolt in the Olympics. Even though all three groups are elite athletes, the way they've trained their musculoskeletal system is all very, very different. As it pertains to your patients, I would say that if you could ask of your patients, rather than doing 10 reps 10 times of a weight 5 pounds, that to do 10 reps 3 times of a weight that's twice as great will ultimately be better stimulus to building up muscle and bone. Because you've turned on the light switch, now you're putting a higher wattage bulb in the ceiling lamp. When you turn on the light, a brighter light comes down.
Okay, so reducing the number of sets is going to allow that light switch to already be turned on if we work hard in that set that we do. If we do one with a heavy weight.
Not quite, I don't think. What I was trying to say is if your patient is doing 10 reps of 2 pounds 10 times, they're still turning on the light switch after the second or third set. So the follow-on 7 sets is not going to turn on the light any brighter. the only way to turn the light on brighter is to increase
The load.
the load, right? And it's the load, by increasing load, is the downstream, as far as those of us that believe in low intensity vibration, is the higher load is actually recruiting more muscles and therefore vibrating the bone that much more, right? So if all I do each day is lift up a letter opener, it doesn't matter that I lift it up 50 times a day or 5 times a day. I've turned on the light switch to be able to lift up a letter opener. It doesn't mean that I can turn around and lift up 100 kilogram weight, right? I have to build up to that. I go from a letter opener, the next day I do a coffee cup, the day after that I start lifting my telephone, that sort of thing. I want to build up the demands on my muscle.
Progressive.
On the light switch, progressively. Yeah. It's not more lifting of the letter opener, it's building from the letter opener to the coffee cup to the telephone.
Yes, and so hence when I designed Exercise for Better Bones, there's a beginner level and then an active level. So that, because if I put somebody at a high level, I know they're going to get hurt somewhere, and then they're not going to be able to lift at all. And so to create a challenge that allows them to safely move and gradually
increase the challenge, right? So it's, as you, and you know, I applaud you for what you're doing with your patients in the sense that you're not asking your patient to come in and do 1,000 reps of the letter opener, right? You're saying, oh, you're doing really well with your 10 reps of the letter opener. Let's increase it from 2 pounds to 4 pounds, 4 pounds to 8 pounds, right? It's not doing 8 pounds 1,000 times per day. It's doing 10 reps of 8 pounds 3 times per day. Okay. That will turn on the light switch.
Okay. Thank you. So Dr. Rubin, we all recognize that whether you're old or young, you do respond to exercise. However, in our discussions, it seems fairly clear to me that, you know, your research has led you to feel that older muscles and bones don't respond to the same level in the same way to be able to stimulate our bone the way younger bones and muscles do. Do you mind speaking to that, and then how the low intensity vibration can bridge that gap?
I could certainly try. It's a great question. So there's been a huge range of studies across the past few decades from around the world that show that a given exercise regime in the elderly, whether it's the frail elderly or whether it's middle age, that the musculoskeletal system just isn't as responsive as it might be in a 20 or 25-year-old. Why is it that if we make sort of an exercise schedule for a 20 or a 30-year-old, they are building up muscle and bone pretty readily, but we prescribe that same exercise regimen for a 60 or an 80-year-old, and the bone and the muscle isn't quite as responsive? It's a tough question, but I think that like many organ systems through our body, that as we age, everything's less responsive, right? And so it gets back to what we've been talking about through this whole session, that somehow we have to stimulate that cell population that's still in your bone and still in your muscle to do the right thing and to build up. Remember, we haven't really talked about is we also have to suppress the recruitment of those cells that come in and break bone down, the osteoclasts, the bone-eating cells. And it turns out that mechanical signals can not only recruit osteoblasts to form bone, they can suppress the recruitment of osteoclasts to break down bone. Right? So it turns out that in younger people, that magic 20 to 30-year-old group that have this exercise regimen, they can readily recruit osteoblasts, and those same signals are suppressing osteoclasts. So it's all good, right? The balance is to build, it's anabolic. But now if we're 60 or 70 or 80, we have less bone cells to recruit to build bone, and this sort of systemic state where these macrophages and osteoclasts are readily recruited to come and break down bone. So a signal that is sufficient to build bone in a 20-year-old may in reality be successful in a 60-year-old, not that it's building bone, but at least it's suppressing bone loss. So even though it's disappointing to be giving an exercise regimen and not build up bone, you're actually succeeding at the end of the day because you're suppressing bone loss. Coming back to your original question about vibration, however, remember that in the elderly population or the less active population, your ability of muscle to generate force is reduced, right? As we age, we're sarcopenic, we're losing muscle mass, and we're losing muscle quality. Therefore, even when you pick up that 10 kilogram weight, the way your muscle contracts changes. So even though the loads are the same, the signals that are generated from the contraction are different. So what we believe we are doing with low intensity vibration is we are actually providing a surrogate for that muscle contractibility. We're tricking, if you will, the bone into thinking that it's being loaded by a 20-year-old muscle, a muscle from a 20-year-old, rather than a muscle that happens to be in a 70-year-old. That shaking that the low intensity vibration provides is actually relative to muscle, it's pretty intense, right? So in the 20-year-old, while they're exercising, their muscle is contracting, bombarding the bone with this regulatory signal that suppresses osteoclasts and promotes osteoblasts, suppresses resorption, promotes formation. But as we age, even though we are still playing tennis every day, that's the nature of that muscle contraction has changed. It's diminished. It's suppressed. It's a consequence of aging, right? The alternatives aren't so great. But by standing on a low intensity vibration device, at least what we believe our science is telling us, is that we are tricking the bone into thinking that it's still young.
Wonderful. So exciting. So in our email exchange, I want to make sure I'm clear. So if we're going to use LIV with exercise, we would prime our cells to receive the exercise. So I mean, in terms of optimum timing, we might, be brushing our teeth, doing our grooming, makeup might take too long to do it, we'll waste our time. But anyways, there's a good 5 minutes of standing on the platform, and we're then priming, the cells to receive or be able to generate more response.
More receptive to follow-on signals.
Yes, yeah. And then that, ideally, we would do that within a 1 to 3 hour period after we've stood on the platform. Is that?
Right. So remember, this goes back to sort of one of the resonant features of our discussion, is that cell adaptation is a transient process. That if you don't keep stimulating the cells, they regress back to this sort of ambient sedentary state, the cell as couch potato. So the challenge in the lab becomes, how often can you give a signal to not only keep it from regressing to being a couch potato, but to turn into an Arnold Schwarzenegger, to get bigger and bigger and more responsive. So what we're trying to do is to arm the cell to be more receptive to mechanical signals. I'm sure that many of your listeners have heard about increasing the sensitivity of a cell to a drug, right? How you get more receptors on a cell surface to be more responsive to drug A or vitamin B. Not vitamin B, but vitamin X, whatever. So now what we're trying to do is to not only get the cell off the couch, now running to imagine your cell running to the refrigerator, right? How many times per day running to the refrigerator is going to make the cell stronger and stronger and stronger. Just as you're asking your patients to lift a weight several times per day, right? And breaking it into bursts. What we believe those bursts are doing, that rest period of 3 hours, and then challenging the system again, what our science tells us is that the cells become increasingly more responsive. So take the couch potato cell, challenge it with vibration or lifting 2 kilogram weights or whatever you have. It will begin this adaptive process. Its architecture changes. Cytoskeletal elements actually form between the nucleus and the membrane. It becomes more robust. If you don't stimulate it anymore, it begins to fall back to being a couch potato. But if you stimulate it, not only is the architecture changed, there are more receptors to be responsive. Now stimulate it again, and it becomes even more and more and more robust. And the downstream benefit of that is, as the cell builds up its architecture, there are that many more elements to be responsive, right? So by stimulating your cells to adapt, turning on the light switch, letting them rest, but not regress, and stimulating them again, say 3 hours later, you're turning on a second light. And then you're turning on the third light. And then you're turning on a fourth light. So who says that there's some magic about 24 hours in a day? Cell doesn't know that. Maybe they do, maybe they don't. But there might be some optimal time period to maximize a cell response. Your doctor prescribes a medicine, for example. He or she says, take this pill twice a day. Why is it that taking it 12 hours later is good? Well, to a certain extent, it might be that it's washed out of the system. But a second benefit may be that the cells have responded and now they are even more responsive to the second time you take the pill. Same with exercise, right? If you turn on the light by that first 5-minute period of exercise and you continue for another 50 minutes, the lights aren't turning on anymore. The lights are on. And now you take a break after that 5 minutes, you wait 3 hours, and you do another 5 minutes, you actually have the opportunity to step up or ratchet up the cell sensitivity to signals.
So we know that with the diagnosis of osteoporosis, the potential consequences that comes with tripping and falling is significant. Often a fracture sustained in a fall is the first sign that somebody has osteoporosis. And justifiably, they're very frightened of falling and fracturing again. So as a supplement to specific exercises like balance and posture and strength exercises for fall prevention, how does low intensity vibration help reduce their fall risks?
It's a great question, and you're absolutely right. It was sort of one of the ironies of pharmacologic treatment of osteoporosis is that it targets the skeleton specifically, if not solely. And it avoids the neuromuscular system, avoids the muscle system. And I believe, and I wouldn't be the only person, that believes that risk of falling and risk of fracture is not just about bone, that osteoporosis or risk of fracture from low bone quality is a consequence of poor balance, poor muscle strength, other elements all contribute, sort of like the holy trinity of bone, muscle, and postural control. So we have actually done studies with low intensity vibration on people standing. And so again, we all, when we stand, we sway, right? And we tend to sway one cycle every 2 seconds or a half a Hertz, right? We sway.
So I'm standing, I don't notice a sway.
Right, you don't know, but if you were 30 years older, you would sway that much more. So as we age, so if you're young like you or older like me, that what happens is that as we age, we sway more and more and more. And we sway more and more for a number of different reasons. One, our proprioception is down, that sort of the way that we sense sway, like the way that we hear or the way that we feel pressure degrades with age. Our muscles aren't as strong, and our ability to correct balance, being off balance, changes. So as we age, we sway more and more and more and more to the point that in the elderly, who might be swaying quite a bit, have a tendency to fall. So going back to what we've been talking about all morning, this idea of vibration, if it is true that we are stimulating not only bone, but muscle, the musculoskeletal system, then perhaps we're also stimulating the neuromuscular system, the way that we perceive things like sway. So we have done studies, as it turns out, of people and the amount of sway that comes from standing up and whether vibration can suppress that. So in a study where we recruited a number of people, it's a study funded by NASA, and these volunteers laid in bed for 90 days without getting up. No surprise to anybody, when they stood up, they actually were pretty unstable. They swayed quite a bit, right? And this is of great concern to NASA. When they return to Earth and they stand up on Earth, they have, lots of crew around to help them stand up, and if they fall and break their hip, they can go to the hospital. If they go to Mars, after 9 months of flying around and they land on Mars and they get on Mars, they stand up and they fall over and break their hip, they can't exactly go to the corner hospital, right? So sway and falling is a big issue with astronauts. So as it turns out, that in this 90-day bed rest trial, half the subjects were buzzed each day. We set up the plate so it could actually be delivered while they were lying down through these harnesses and straps. So it was loaded up through their skeleton. And lo and behold, those in the buzz group swayed significantly less. Not only the amplitude of sway, but the velocity of sway. So again, it was this sort of issue that we've been talking about throughout this entire interview, which is that use it or lose it. So if you're an astronaut or if you're a couch potato, not using your musculoskeletal system, it as a system will begin to decline. So for your subjects worried about osteoporosis, not only must they be worried about their bone quantity and quality, they must be worried about their musculoskeletal system, their ability to control their balance, and having the muscle strength to protect themselves when they do fall.
Very good. I have individuals whose bone mineral density scores are several standard deviation points below normal, i.e. a T-score of -3 or -4. is, or lower, is LIV a viable option for them?
So I get to ask this question quite a bit. People call me up or send me an email, et cetera. And my first response, and to you and your listeners as well, is there are drugs out there, anti-resorptive drugs, bisphosphonates, or anabolic drugs like parathyroid hormone that are in the US FDA approved for the treatment of osteoporosis. These are very, very good drugs, and for people who are frankly osteoporotic, T-scores of -3 or -4, they need to build up their bone in any way possible. The first advice I would give them is to speak with their physician and come up with a strategy that may include anabolics or anti-resorptives to build up their bone, because these are proven FDA drugs with indications for the treatment of osteoporosis. Low-intensity vibration, at least in the US, is not an approved intervention for osteoporosis. We have shown across many studies that we build bone. But in answer to your question, my first bit of advice would be to make sure that your subject, your patient, considers the use of drugs. A lot of people just don't want to take drugs. There are some side effects, some of which may be severe. A lot of people don't want to commit to years, if not decades, of use of drugs to prevent a disease. I'm sort of in that camp. I mean, one of the reasons I do what I do is I want to come up with non-drug strategies to treat disease, because who wants to take a drug, right? What we have found, and this is what's called a post hoc analysis. It wasn't an a priori analysis, but after our clinical studies are completed, we can go in and dredge around the data and ask follow-on questions that may not actually test our hypothesis, but give us the ability to look more closely at the responders, those people who responded, versus those people who did not respond. And the data suggest, not conclusively, but they suggest that those with less bone, those with lower T-scores, as it pertains to your question, actually, strangely, tend to be more responsive to vibration than those with higher bone. Is that the case of why a healthy 20-year-old may not respond to vibration because they've already sort of optimized their skeleton? Maybe, I don't know. But certainly, and there is this study coming out from the University of Pennsylvania in the Journal of Bone and Mineral Research very, very soon. Actually, I think it's now on the web, that shows that low-intensity vibration not only stimulates bone, but appears to stimulate it more in those that have less bone to start with. Maybe, I don't know, but in trying to understand why that might be, a signal in a structure, a given signal, our low-intensity vibration, in a structure, your bone or my bone, if there is less bone for that given input, the resulting signal is that much greater, and therefore perhaps stimulating more of a response. Just like if you drive a truck over a big, robust bridge, the bridge pillars don't actually shake very much. But if the infrastructure of that bridge, if the pillar of that bridge is really corroded and rusted, that truck drives over it, that pillar shakes quite a bit. So maybe that's why, I don't know, but it's certainly an interesting response.
I have not read that paper yet because I looked for it yesterday. Do you happen to know, or are you in a position to state how many minutes they used the...
So they used 0.4 G, 30 Hertz, low intensity vibration signal. I believe if I remember correctly, it was 10 minutes per day. This is in a group of postmenopausal women. And they used MRI and CAT scans to look not only at the quantity of bone, but the quality of bone. Remember, we were talking about trabeculae, how the bone is actually put together. And what the MRI signal is able to show is that not only are they improving bone density, they're improving the way the bone is put together. So they're stimulating the connectivity of the bone. So that's something that we haven't been able to do because we haven't had the imaging resolution to look at the way the bone is put together. What makes this study so remarkable, at least to me, is that their imaging modality is such they have the resolution to look at individual trabeculae and show that they are actually building up connections, making the bridge stronger.
Wow, this is very wonderful, very exciting.
Yeah, it's cool. Very cool. I wish it was me.
Yes. So with that study, somebody, and I have them, I have clients that, they're triathletes, they love movement, they will do anything to get their bones back in order through mechanical stimulation. So they're going to ask me, if, and then, we modify their exercises so they're not doing extreme things anymore. But, they're going to say, therefore, should I stand on that platform 10 minutes every 3 hours for maximum gains? And I know they'll do it. So I need to know.
Yeah, nothing like a committed athlete, right? Or an athlete that should be committed. I'm not really sure. But we're extrapolating here, right? I mean, you have to remember that I'm a scientist, right? I believe in the data. We try to make sure that our studies, be they clinical or cell, are done really rigorously. And I'm sometimes uncomfortable at sort of projecting about what an ideal regimen might be. I mean, certainly a collaboration between you and your patients in understanding the science. I think you're as well placed to extrapolate from the data that I provide as anyone. That said, if we can extrapolate for a moment, what we have shown in our cells and in our mice, that breaking up the signal, the duration, the bouts, into several bouts per day, separated by between 2 to 3 hours, we can begin to ratchet up, climb up, increase the anabolic nature of the signal. Have we shown this clinically? Well, I will point to a study done at St. Jude's Hospital by Curie Ness using low-intensity vibration on kids that had basically their cancer was in remission, that they were able to show that by standing on low-intensity vibration device, they were able to build up bone in these kids, right? Which is a good thing. The curious thing about Curie's study is that she did it in 2 doses per day, right? And whether she did that because maybe she thought that our refractory period story made sense, or maybe it was that these kids didn't want to stand on a device for 10 minutes a day, but were willing to do it for 2 5-minute treatments per day. But the point being that they turn on the light with the first 5-minute switch because they're young, healthy children. And by waiting at least 3 hours and challenging their skeleton again, they got a nice response. Would it have been as good a response if they just did it 1 time per day? We just don't know because we haven't done that study. But I would suggest to your triathletes who some of their bone complications may come from a host of reasons, as you know as well as I do, chances are they know it as well, that their whole chemistry of their body is changing, right, by being these extreme athletes. And so all these catabolic signals that are breaking down bone and muscle that are coming from over-exercising or training so hard, whether buzzing, standing on a plate could help them, maybe by doing it several times per day, could it help them more? Maybe. Can I say with 100% confidence? No, because we haven't done the study.
Okay, and so lastly on that thread, can they overdo it?
Well,
because some of them will stand on it for hours.
So I'll go back to where our conversation began, where we were talking about high intensity vibration versus low intensity vibration. And I would turn to what I actually believe in, which is this international standards organization, the ISO 2631, which are these international standards for human exposure to vibration, right? Remember, we challenged that advisory with high intensity vibration, where exposure was not safe for even 16 seconds per day, i.e., do not stand on a paint shaker, period. Our device is considered safe for between 4 to 8 hours per day. So can you overdo vibration? I mean, remember that vibration is a pathogen, right? It causes white finger disease, causes blurred vision, could cause ringing in the ears, causes low back pain, etc. But these are from occupational exposures of vibration that are much, much higher than what we deliver. And it would break my heart, literally, if somebody listening to this said, oh, Dr. Rubin says that low intensity vibration is good. Well, higher vibration must be that much better. And particularly those listening might be those with poor bone quality. It is just those people who are at greatest risk of harm from high intensity vibration. So do I worry that your triathletes will do too much of a good thing? Well, I'd say that they need to train less, not stand on a plate more. But my guess is these committed athletes their bodies tell them a lot. And maybe, and I would love for them to reach out to me if they stand on a device and they actually feel better, right? Because it is recruiting our mesenchymal stem cells from the bone marrow to build muscle, bone, ligament, tendon, just as we've talked about, and suppressing fat, which we've shown even in the clinic. Maybe it can help them. And if any of them win an Olympic gold medal, make sure they tell me.
Okay, but I know some of them already have very low bone density.
They do. Yes, they do.
Yeah.
And we're going right back to, these are extreme athletes that are doing this redundant activity, which is couldn't be a better example of more is not turning on the light any brighter.
Okay.
In fact, it's starting to fight the light. To turn the light off.
Thank you. So with our next question, my mind goes to the other extreme of my clients, and that is those who already have a deterioration of their bones, and so they have one or several vertebral compression fractures. So I know that unlike walking and running, that we know is more limited to stimulating the lower body, that the vibration when you're standing upright on the platform, the vibration of the low intensity vibration can come up to the level of the spine and head. I know you said there's no contraindications to, pretty much for,
None that we found yet. I mean, right.
So any words of advice for people with vertebral compression fractures?
So again, we have, our lab group has not studied compression fractures and whether vibration is good or bad for them. There is a group in Hong Kong that has published work on femoral neck fractures. So they actually put their subjects on low intensity vibration devices and show that it can accelerate and augment healing. So we have done studies in fractures, and we've done studies on ingrowth into implants and shown that these extremely small mechanical signals can be anabolic to the healing process. So you would be correct in reminding me that the transmissibility, how much of that mechanical signal goes up through the spine, could well be reduced across a fracture. But the beauty of it is, because rather than being a tight bone, knit bone like this, now a fracture where the callus is not as stiff as the bone, that same mechanical signal will actually magnify the signal at that site of the fracture. So we have shown, at least in animals, and our colleagues in Hong Kong using low intensity vibration have shown, that these signals actually accelerate the healing of fractures. So people who have had osteoporotic fractures, including a clinical trial that we have done on young women with osteoporosis, their inclusion criteria being they had to have had a fracture to be included. We have never shown an adverse event, a delayed or a non-union due to the vibration. And several people actually believe that it helps them accelerate the healing of fractures. I'm not saying that. I'm saying that our animal studies have demonstrated that we accelerate and augment the healing of fractures with these vibrations, and that there are clinical studies done, not by our group, but by a group at in Hong Kong, Chinese University of Hong Kong, have demonstrated that they accelerate healing in fractures.
Okay, so if a question comes in, and that is that oftentimes when the prescription that someone should wait, the 6 to 8 weeks after a new vertebral compression fracture before they exercise, can I safely say that although they should still practice good body mechanics, they can still work on balance within safety, realm of that support that they need. But do you support me in saying that it appears that it is safe to stand on a vibration platform, even within?
Right. So it's another great question. And you're right that with a vertebral fracture, and my guess is that your patients tell you exactly this, that picking up grocery bags or picking up their grandchild or something is too painful. That pain is a great reminder that you have a healing fracture. But you also need to remember, if we go back to walking down the street, that the impact of your heel, it's called the impact spike, your impact heel strike on the ground, generates an acceleration of around 1.2 g, just above Earth's gravitational field. We are at 0.4 g. So when you think of it in the context of a patient with a fresh fracture of the vertebrae, that we are actually putting less of a mechanical challenge to the region of repair than walking down the street. But biologically, we're sending this big signal to the cell population that says, heal. So if they could tolerate the pain, sure, we tell them to go out and lift 100 pounds 30 times a day, but pain's not going to let them do it. Then it could do harm to the healing callus. But if we could send in the good part of mechanical signal without putting it at risk from the bad part of mechanical load, then I'd say, yes, it's safe.
Thank you.
I'll try.
So
That's great questions. How could I shut up?
So when it comes to bone and muscle, because we know the vibration platform helps that. And we know that exercise, if it's continued, from when you've optimized your muscle health at 30, if you keep lifting, you could maintain, as opposed to letting the muscle turn to fat, you could maintain that muscle health to a fairly significant level, maybe 70% of your max by the time you're 70, compared to 30. Would you say that is a possibility with bone as well?
Oh, I think it's absolutely a possibility. I think that the goal of bone health is to keep as much bone as you can for as long as you can. So while you are young and active, 35, 40, 45, 50, the more active you are, not only are you suppressing the bone loss, you might actually still be stimulating some bone gain. Remember, 5% of your bone is turning over every year. So there's a tendency for the bone remodeling to go out of balance and to begin to decline. So if the slope down can just be made a little less steep, then by the time you get down here to 80 or 90, you have more bone than if you were dropping like this. This is a good thing. So whatever activities you can do. So rather than taking drugs from 40 to 50 to 60 to 70 to 80 to 90, 50 years of taking osteoporosis meds, if for that first 40 years you can remain very, very active and avoid taking drugs, great stuff. But if you are at risk of fracture, if you are osteoporotic, you do need to act, because once you fracture, lots of systems start to fail, right? You just aren't as active anymore. So avoid swirling into that whirlpool.
We talked about the low intensity vibration platform, going up through the legs, through the torso, through the spine. And, because we always talk about hip and spine, because those are the measuring points in a DEXA. What about our arms? Does the vibration from a low intensity platform reach our arms? Because wrist fractures are a big issue.
Right, wrist fractures are a big issue, and wrist fractures are an issue from falling, right? I mean, like they spontaneously fail. A Colles fracture will occur because you trip and fall, or you lose your balance, and you hold out your palms to keep yourself from falling, which is where the ultradistal radius or whatever might break. We have not studied the upper extremity, but I believe that it is the acceleration from the vibration that's transmitted up your lower appendicular skeleton, your femur, and up through your axial skeleton, your spine, that's actually generating the positive response. So I would be surprised if there's an upper extremity benefit to this. There is a group in Brazil that has used low intensity vibration in subjects that are wheelchair bound, where they actually take vibration and they stimulate the upper extremity with vibration, and show that these people can generate more power with their arms following this. So it's consistent with, but simply standing on the device, I would guess, unfortunately, that there's not going to be a huge benefit to your arms.
Okay, so then I have folks, that are recovering from fractures. So, and I also have, been approached by people that are professional musicians, and for, reasons of overuse, cannot lift heavy, and they're so frightened because it's their career, and therefore, how do I can't get them to lift because they don't want to lift, they don't want to hurt the little joints, in the grip. So so I'm going, could they put their hands on a platform?
They're certainly welcome to do that. I mean, I have no evidence that it would be a benefit. Certainly have no evidence it would be of harm. What we have to remember is that the recovery from injury, so in the case of a musician, it's an overuse injury, right? There's all sorts of things going on in the joints and the muscle and the bursae, your tendons, ligaments, etc. All sorts of things going on, inflammation, etc. That to think that vibration will somehow or cure them, it is a bit of a reach, no pun intended. Do I think it will do harm? No. Do we have evidence that vibration reduces inflammation in cells and animals? Yes, we do. Have we ever done a study on somebody that has chronic overuse injuries and treated them with vibration? No. So I can't quite answer your question in the way that you want me to, but I see no reason it would do harm.
Okay, so my question possibly wasn't totally clear in that they've had a ton of therapy for their injuries, but they have low bone density in their arms. It's just trying to find a way to improve their bone density without re-injuring them, through heavy lifting. Or
I certainly believe that the responsive elements in your humerus, your ulna, your radius, in your digits, etc., that there is no reason to think that the stem cells in there or the bone lining cells in there are any different than they are in the leg. Once you sort of get up in your head, the stem cells actually are different. They're neural crest stem cells rather than mesenchymal stem cells. But yeah, for the same reason we know that professional tennis players have 30% more bone in their playing arm than their non-playing arm, that is an adaptive response to a mechanical challenge, which I believe is to some degree due to the vibration of the muscle. Do I think that your chronic overuse subjects could potentially benefit in their bones of their arms from vibration? Yes, I do. Is there clinical evidence of it? I'd have to look more closely at the group from Brazil. Maybe they have done studies that have looked more closely rather than force output. They've looked at bone density. If you email me that question, I can do a quick scan and send you the paper if I can find it.
Thank you. We're going to move into the area of pharmaceuticals and LIV. And so we can try to keep this as brief as possible.
Yeah.
So do you know if the effectiveness of LIV is the same if someone's been on a bisphosphonate for years?
So let me answer the question with yet another study. So Belinda Beck, down in Australia, down under, is at this very moment doing a study with, we are doing a collaboration with her, with low intensity vibration plus osteoporosis treatments. So bisphosphonates plus vibration. Because remember, bisphosphonates are stopping the osteoclast, the bone-eating cells, but they're not stimulating the bone formation cells. So the reason that when you take a bisphosphonate, an anti-resorptive, and that it builds bone, is not that it's stimulating bone to grow, it's stopping bone from resorbing. So if buzzing is anabolic, it stimulates bone. In one hand, you're buzzing bone to grow it. In the other, you're taking anti-resorptive to stop the loss. Then there might be a synergy. I don't know what the results of that study are. It's called a double-blind, placebo-controlled trial. And we won't know the results until the code is broken. But let's hope that's the case. In another collaboration with Teresa Guise, G-U-I-S-E, and Gabe Pagnotti at MD Anderson in Houston, they're very interested in breast cancer. She actually treats bone loss in women that are fighting breast cancer. And the problem with breast cancer is not only does the disease haunt the bone quality. I mean, it does a lot of nasty things, don't get me wrong, but from a bone perspective, it can actually cause quite a bit of osteopenia, osteoporosis, and osteolysis in bone. Not only does disease do that, but the treatment can also accelerate the bone loss. So even though the primary outcome is to help contain and reverse the disease, the consequences of the treatment, the consequences of the disease, are really poor bone. So they have now done a study on their mouse model for breast cancer, have shown that a zolendronate, a anti-resorptive, can slow the bone loss in their mouse model. That vibration, putting these breast cancer mouse models on vibration, can slow down the bone loss. But together, the synergy of it is they actually build bone. So that, you know, in a disease cohort, right, we're not young, healthy adults anymore. We're fighting a disease. Drugs have a big task before them, just like vibration has a big task before them. Perhaps its combining forces will ultimately be the way that we approach this. But her data, Teresa and Gabe's data on their mouse models is incredibly exciting to show that something as simple as a mechanical signal can work together with these really sophisticated drugs to really help clinical endpoints.
So that's excellent. And so obviously I had a few other questions, but it sounds like you're just entering that whole domain of, you know, the pharmacotherapeutic approach combined with LIV, because I was going to ask you about Prolia and about, you know, your parathyroid hormones. Anything on those fronts?
No, you know, it's pretty. I've come back to this point a couple of times during our conversation. It's relatively easy to do studies on cells because they're down the hall in my incubator, and it's relatively easy to do studies on mice or rats or turkeys or sheep. You know, the sort of the barnyard animals that we use in our lab. And, you know, it's really wonderful, and it's a great privilege to do these preclinical or animal studies because they give us so much information. But the hardest work that I have ever done in my 40 years of being a scientist have been clinical trials. They're insanely expensive. They're incredibly difficult to recruit patients into. And just as you've challenged me with, so many different questions we can ask. So yes, I have a chalkboard in my office next door, which has this list of menus of clinical trials I wish I could run. So maybe one of your grateful patients will send me a $10 billion check in Canadian dollars for all I care, and I'll do all these clinical trials. But until that occurs, it's a slow road. It's tough. So I'm incredibly grateful to my clinical colleagues, Belinda, Teresa, Kiri, all these places we're doing these clinical trials all over the globe. But boy, it's a long wait.
All right. So listeners, you know where to send your donations.
Yeah, right.
Now, when someone uses a platform, with a high intensity platform, they suggest bending your knees because...
No, with high intensity platforms, the suggestion is to run out the door.
Oh, okay, good point, yes. But I'm going to be back here.
Yep.
So, and you can see my knees against the clear background, right? Now, this is straight knees, correct?
Nice relaxed stance, straight knees, yes.
Now, some of us hyperextend our knees. So this is me hyperextending. As soon as I hyperextend, I am not using any muscle function to stand. I'm hanging on the ligaments of my knees, of my hips. I feel this tension of doing that, and it feels totally uncomfortable. So I constantly tell because I have a lot of hypermobile clients, and I constantly tell them to stand with a very little micro bend so that their muscles are holding them up as opposed to their ligaments. Is that the way they should stand on the platform, or do you want them to hyperextend?
No, a great question again, and thank you. So we have done studies where we've actually stuck what are called Steinman pins into people's trochanters, their hip and their spine, and put these little microphones, these accelerometers on them to look at what's called the transmissibility function. How much mechanical signal from the floor, the bottoms of your feet, are delivered to your hip and to your spine. And as we talked about before, that as you bend your knees, sort of 60 degrees, 90 degrees, even in a squat.
So more of a deeper bend.
Right, much deeper. That essentially the signal disappears because it's all lost in your knees. But really subtle adjustments of stance don't necessarily affect transmissibility. So I would suggest to those subjects that are considering the use of the device that any way that they could stand for 10 minutes comfortably is the way to go. Because remember, it's not the muscles you're using during your postural activity that's stimulating the bone when you're sitting on this device. It's the acceleration up and down that the plate delivers, right? It's telling your body that you're being challenged by a 20-year-old mechanical challenge rather than a 70 or an 80-year-old one, right? So, it's the next time you're standing on a sidewalk and a truck rumbles by, you can actually get a sense of how that vibration transmits up into your skull from the ground, up the shaking of the truck into your head. Then the next truck that comes by, bend your knees to 60 or 90 degrees, and you'll find that the sensation in your head is gone, right? But whether you're hyperextended in stance or relaxed stance, that truck is still going to shake your head because it is the tibia to the femur. It's the connection of that is actually transmitting as a wonderful transducer up to your spine. So it shouldn't matter.
Perfect. Yay, because I'm happier with a little micro bend. Okay, now, last question, promise, is because we talked about sway as people get older. And so do they lose anything from resting their arms when they're on the platform? Or is that totally, they're going to gain as much benefit if they're resting their arms? And I'm thinking about standing workstations where your forearms are resting during the time that you might be standing on the platform.
So our early studies, and including our studies with kids with disabling conditions like Duchenne's or cerebral palsy, that we created standing frames because people are told, oh, you're going to stand on a vibrating platform. Oh, you better hold on, for dear life. And so we set up the platform so there were little hand rails. And we thought that this was a way of making sure that people felt more confident and comfortable. But once they turn the device on, they feel how subtle it is. Sooner or later, usually within the first couple of seconds, they let go. And it's just an issue of standing. From my view, if they are more comfortable resting their hands on their work desk, or they have it next to, a stair rail or something, and they feel more confident, and therefore use the device more, I say go for it. But they're going to find pretty quickly, including our kids that have been in these trials, sooner or later, they start reading a book, etc. And from my view, not only is that sort of address the issue of safety, do I need a rail? And if I was really unstable, I'd want to put it near a desk to keep myself from falling. But in reality, your postural sway is a way of keeping your muscles active, right? The bottom line of our conversation has been, movement and exercise is good. Postural sway, to a certain degree, is a good thing. So activate those muscles, stand on the device, and wherever you feel safest and most confident, I'd go for it.
Okay. And very, sorry, I said it was very last. If somebody chose to do some light exercise with their upper body, doing some weights, that's fine too.
It's fine. We haven't done a study of combined exercise. Again, these studies are so expensive and time consuming that we try to keep all the variables to a minimum. But the device is smart enough that even if you are swaying, or even if you're reaching over, picking up your coffee cup, or doing, I wouldn't lift 100-pound weights on it, but 2-pound weights on it, the plate is smart enough to adjust the signal as you are sort of migrating around, that it will continue to deliver the 0.4 G, 30 cycles per second signal to it. It's just like if you or your husband, who have different body types, body habitus, the plate is smart enough to recognize that the way it delivers the signal is different for you than it is for a kid with Duchenne's, than it is for your husband, than it is for some massive person who happens to be a weightlifter or something. Because the amount of force required to lift that person will change depending on their mass.
So you mentioned at one point that the device that you have, the low intensity vibration, has been approved for osteoporosis in Europe. What is the status, do you mind, or do you know, in terms of approval as a medical device in the US and in Canada?
Right, I can try to explain that. And again, reminding everyone who's listening that, I do have a conflict of interest. I'm a founder of the company that actually manufactures them. I'm insanely proud of that conflict, and I think it's actually a good and healthy thing. But remember that conflict exists. So yes, we have gone through the regulatory agencies in Europe, and we are approved for a number of what are called indications, osteoporosis being one of them, things like low back pain, something we didn't talk about here so much. Some of our clinical trials have dealt with low back pain. Other indications, I believe that the Meridyne low-intensity vibration device is being reviewed by Canadian Health now. I'm not certain of that. I don't know what the status of it is. I try to remain somewhat distant and divorced from it and remain just a sort of a wild-eyed scientist in my lab. In America, we do have approvals and some indications like an exercise surrogate, et cetera. Those are indications we have. But the challenge of getting an indication for osteoporosis, let's say postmenopausal osteoporosis, is that changed 20 or so years ago, that your clinical data needs to actually demonstrate a reduction in fracture incidence to get FDA indication for osteoporosis. It used to be just an improvement in bone density, which we have the data to demonstrate, but we don't have, the $8 billion that Merck has to do a clinical trial of the size and magnitude and length of study that can show reduction of fractures. So instead, I believe our strategy will be to go back to our studies in kids with cancer, or kids with Duchenne's, or kids with cerebral palsy, these kids that need to build up their musculoskeletal system. And because we have no adverse events, we believe, with the help of parent groups, patient advocacy groups, et cetera, that we can go to the FDA for indications for health of musculoskeletal health in the adolescent skeleton. And then, physicians can prescribe these devices for those that want to consider them. Remember, and I apologize again to your listeners, these devices cost money, and not everybody has this sort of money, right? And it's not, and at least in the US, it's not reimbursable yet by insurance. So getting indications is just one milestone. The next one is get approval for reimbursement for insurance companies. So until that happens, you can always get a device and share it with your neighbor, I guess, cost share it. But that's where we are with regulatory indications. We're proud of where we've gotten to, but we have a long ways to go.
I'm cheering you on.
You pointed out that bed rest is bad for bone. Bed rest is bad for all of your physiologic systems. It's really nasty. We're doing studies now where we're looking at the possible use of vibration for patients in the ICU. So patients that are basically in chronic bed rest that can't get up and exercise. Is there a way that we could mechanically challenge their organ systems to be tricked into thinking that they're still being mechanically loaded? Because it's not just the skeleton that suffers from inactivity. It's all of your systems. Even think of, and I'm not suggesting that LIV is good for your brain, although we are studying it, that exercise is good for cognition, right? People tell you they think more clearly, or you read New York Times articles about studies where exercise is good for your brain. Well, maybe it's mechanical signals as well, because there are neural stem cells, just like there are other sorts of stem cells. They're trying to figure out what to do when they grow up. So that's a bit of a reach, but we are actually studying the neural system in response to mechanical signals. And we have shown the neuromuscular system, how neurons activate muscle activity, actually improves with mice standing on a device. Let me put it in the context of low intensity vibration, because that's sort of the soul of what we're talking about here. So why vibration? Why 30 hertz, 30 cycles per second, where in reality, even if you're Usain Bolt sprinting in the Olympics, you're only running at 2 or 3 hertz, 2 or 3 cycles per second. How crazy can it be to do something at 30 hertz? Well, it's interesting because even though we're walking or running at 1 or 2 hertz, our muscles, the way we pick up our coffee, for example, are really inefficient motors. They're actually vibrate as they contract. So where is this vibration, this bandwidth of muscle contraction? Lo and behold, it's between 20 to 50 cycles per second. So a lot of people ask, why, Clint, why are you possibly shaking people at 30 cycles per second? It goes back to us being a surrogate for exercise or standing. What is it that you and I do most of the day when we're active? We're standing. And your muscles, when they're contracting to allow us to stand, are bombarding your bone tissue, not with 1 cycle loads, but with 20 to 50 hertz vibrations from your muscle. So what we're trying to do is put that vibration back into the system for the people who are not as active. As it turns out, and nobody is more surprised than me, when we try to look at how the cells respond to load, to taking a cell and squishing it 1 time per second, we find that cells are very responsive. All of the cells in our body, every one of them, is mechanically sensitive. In bone cells, we tend to think of, let's walk our bone cell, let's load it like this. We found it's very responsive. Well, let's run our bone cells, let's load them more often and more quickly. They're even more responsive. The challenge in a lab becomes, for my graduate students who actually do all the work, is they run out of time in the day to, well, let's ask the question, how long do you need to load, or how many cycles? Mm-hmm. And what you find is that, well, if 100 cycles is better than 10, maybe 1,000 is better than 100. It takes a long time to do 10,000 cycles at 1 cycle per second. So we thought, let's cheat nature and let's do it really quickly, right? Because you can do 10,000 cycles at 30 cycles per second, much 30 times more quickly than you can at 1 cycle per second. Lo and behold, the cells lit up like the night, was it Aurora Borealis? They just went crazy.
Oh, wow.
Wow, they're frequency sensitive. But then you think about all the systems in your body, not only are mechanically sensitive, they're frequency sensitive. If you listen to me as I change the tone of my voice, those are the mechanosensitive cells in your ear that are picking up changes in frequency.